How do you guide your client in their decision to get a tummy tuck? Join Lisa Ryan and Munira Hundani as we discuss the ins and outs of this major decision for our clients. Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. Welcome, everybody. Today we have a very special treat for you. We have two rehab professionals with us that we're going to be talking about abdominoplasty with. Lisa Ryan is with us here. Lisa is a level 2 CrossFit trainer, and she is a pregnancy and postpartum athleticism coach. Welcome, Lisa. Thanks for being here. And then we also have Munira Hundani, who is a physiotherapist up in Alberta, Canada, and she specializes and has a special interest in diastasis recti and the abdominal wall. Welcome, Munira. Thank you for being here. So, okay, we are going to be talking about how we can best support our clients in their decision on their journey of healing when we're dealing with diastasis. And we all know that diastasis can be as small as 1 finger gap to up to 10 finger gap. And so there's this massive range. And I know in my mind, when I think about abdominoplasty, I kind of have this assumption that it's really for those that are, 5 to 10 finger wide, so really large gaps, right? You're like, oh, you see that large gap, you think, oh yeah, they might need surgery. But is the smaller gaps actually possibly a surgical candidate as well? And should I be changing my thinking?
That is such a perfect question, Lynn. And it kind of goes to the idea that we as professionals, we always have to check our assumptions. And at the same time, especially when it comes to diastasis surgical repair, um, be open to not necessarily what we think needs to be done, but what the patient or client is hoping for. So in your question of do the smaller gaps, do they tend to not need surgery compared to the larger gaps where we assume they are the ones that will need the surgery? It actually turns out that a lot of people who have smaller gaps are still unsatisfied with the way they look. So when we're always taking into account the aesthetic component and also the patient's goals and what they want, we actually end up seeing that even those with smaller gaps, they may still opt for surgery. We can say you're functional, we can do all the exercises with them, and even then they may not be happy and still haven't met their goals for what they want for their body. So yeah, it's not as clear as measuring a diastasis and then saying you're a surgical candidate and you're not. When we look at the whole picture and we kind of discuss this openly with the client on what their goals are and what they're hoping for, then we see actually there's a lot more nitty gritty to that discussion.
Right. Well, I'm imagining that, as rehab providers, we really need to check our biases at the door when we're working with our clients that have these gaps. And, because I can't, I'm sure we've all seen those people that only have a 2-3 finger separation, but yet they're doming or they just don't like the look of their belly. And they're the ones that are more likely gonna want the surgical route, even though we're like, you're fine. And to me, that's just, I think that's really a challenge for us as practitioners to go, that's a huge surgery for you to go under when you have a really functional, core and you're strong, but you just don't like the way the belly looks. For us to have to, put that aside, really, right?
It's very hard because it's very hard because there are other issues there too, right? So if they have a lot of extra skin, do they
Mm.
have an umbilical hernia? Even if the umbilical hernia isn't an emergent issue, if they're going to get that fixed, they're like, well, might as well get the muscle repair too.
Yeah.
right? And then, okay, they want to get their skin tucked up, which is not as an invasive surgery at all. But then, a lot of the surgeons are still going to say, well, let's do the muscle repair too, right? So I think that's another conversation to have. If you think there's someone that you could just get your skin tucked up and leave your muscles alone, you just want to kind of educate them about it, not shame them or say you shouldn't do it, but just explain the difference between the two surgeries, how much harder it is when the muscle repair is a part of it, and then you're going to just let them make their own decision.
Yeah.
But if because there's so many different situations, right? Leave the diastasis, leave the hernia, none of it's that bad. Person feels functional and strong and they're happy, hooray, right?
Yeah.
Hernia that's bothering them and then they have a minor diastasis, is it worth it to just do it all? Maybe, maybe not. But those are all going through each scenario of like fixing this, not fixing that, doing this, how much extra skin do they have, right? And just opening the conversation in a non-judgmental way.
So Lisa, what is it that we need to let our clients be aware of in those different surgeries as far as recovery goes? Like, what don't we need to educate them on the expectation of what they're going to experience
Right.
as a provider?
Yeah, I think that's one of the most important things. Not, again, doing it in a way that you're trying to scare the crap out of them,
Right.
but be very clear, because most of the people that we have talked to while we were creating our program, just online, working with clients, is that recovery was a lot harder than they expected. Not everybody. I worked with someone where it was like almost a breeze. And I was like, wow, this is great.
Well,
So,
don't you feel the surgeons undersell
absolutely
the recovery process?
Absolutely.
Yeah.
Absolutely.
100%.
Absolutely. 6 weeks will be fine.
Yeah.
It's like, no. But sometimes, but you can't plan for that. So I think that that's a good conversation to start with, where I just want to educate you, because this is something that's not talked about enough, versus I don't want to scare you away from it, but like I want you to understand really what the surgery is.
Okay, so can you share with us, like, what's the difference in just getting the skin taken care of versus when the muscle's involved? What's the big difference for us that we should be aware of to educate our clients about?
Yeah. Most commonly they are done together, but when they're done separately, and what I'm thinking of is maybe someone who has lost a lot of weight and now they have quite a bit of loose hanging skin. So it's merely a removal of skin, subcutaneous tissue. So the recovery is rather superficial. Like the wound is superficial, they're not doing anything deeper than that. Once we start considering the muscle repair, or at least the diastasis repair, then we're talking about fascial healing. And there are additional sutures and techniques that are done underneath the skin that we don't actually see when we're looking at our clients. We just have to be aware that stuff had happened underneath it. The recovery for that is much longer. Skin in general can certainly heal and close up, and that's usually what the most important thing is: make sure the incision is closed. And there may be some issues with the scar, maybe some wrinkling. There's also something called dog ears, where at the end of the incision there may be like a fold over of the skin, so it looks like dog ears. So with regards to just skin or just superficial stuff, we are, we're talking about just kind of superficial incisional healing. Once it's healed kind of thing. And then, but when we're talking about fascial manipulation and surgery, then fascia takes much longer to heal. So we're comparing 4 to 6 weeks for skin potentially, and then comparing that to like a 3 to 6 month recovery for fascia.
Okay. And then, so the fascia being more with, the fascia going around the muscles, and that, is there fascia that they interrupt when they're just doing the skin and the subcutaneous, or not?
Well, they don't go down into the abdominal wall muscular
Okay.
layer. Yeah.
Okay.
Yeah.
So
There
then
is
there's no fascia.
superficial fascia. Yeah. They do have to sort of separate the
Yeah.
layers, but they don't
Okay.
actually disrupt the fascia.
Yeah. Anything you want to add to that, Lisa?
Yeah, I think it's just a little bit more, you know, and even with people that have lost a lot of weight, sometimes they also have the muscle repair as part of it because
Yeah.
everything was right.
Yeah.
So, and with women that have had babies, I think a lot of times they go in because they have all this extra skin, and then sometimes they almost get any little diastasis they have. They're like, let's do the whole thing, you know, like, so it's just good for them to understand that's still an option for them if they really want it, but it's good before they go into those consults to explain to them. You think they'd be a candidate where they have tons of extra skin, but their diastasis isn't so bad. Tell them, like, this is an option. They're going to sell you on this. It doesn't mean you do or don't have to do it, but just having that awareness going into that can be very empowering for women, and then they can make their choices.
And functionally, if we're saying that there's a very small gap, functionally they're still okay. They don't really need the stitching up is what we're kind of letting them know, but that is an option. And some doctors will actually throw in a few more stitches. That may then change their recovery time and process. Yes.
Yeah,
Yeah,
absolutely.
especially if if they absolutely go in and do some work on the linea alba, that will change the recovery time. But it also, so there's also a difference between a full muscle repair, like a full diastasis repair, and a mini tummy tuck. Mini tummy tuck is usually just done from the belly button to the pubic bone. So it's for people who don't have too much happening above the belly button. And so even though they are going into the fascial layer, the linea alba, the recovery for those are still a bit easier than the full tummy tuck going all the way up, because then they have to separate the skin away from the rest of the abdomen the whole way up to the rib cage. And they have a lot more work to do up there. So yeah.
Okay. Wow.
That can be tricky because sometimes I had one person who did have that, but then was really upset because their top, even though they didn't have an extreme, it just looked like it was pooching over because it was. There's so many layers to it that people want to just make sure they get lots of consults, learn about it, but that's where we can kind of guide them.
Yeah, and I think
that, like look into this, look into this, look into this, and just give them the information to look into.
And I think that in having this discussion with our clients, we can also let them understand that it's not the easy way out. And so sometimes they feel like they're kind of cheating themselves or cheating the system, or just cheating in doing something that is supposedly something that's supposed to be really hard to achieve. And yet they go for the surgery and they're like, well, I don't think it should be this easy, but we have to let them know it's not that easy. And there are lots of things that you can experience along the way. I mean, it's hard physically to recover from a surgery like this. It's hard emotionally. It's its own roller coaster of emotions post-op, and it's hard financially. It's not, it's a lot of money for a lot of people to go. So it's not an easy decision to make. And then we're talking about the results, like what Lisa was just saying. We really don't have any guarantee on what you're going to look. It's likely going to be better. But in some cases, depending on what you're going in with, it may not be better, or it may be better, but not exactly what you wanted. There will be an improvement, not perfect. So it's not an easy, light decision for someone to make.
I had a client that I worked with who she had mesh put in, and the doctor didn't put the mesh up high enough. And so she had this, mesh of thing, and then this bulge just right above the mesh, and it's like, there's nothing you can do about that. After that's done, it's done. And so she ended up having a very long journey of getting the mesh taken out and then sewn back up and then splitting it open again because she moved too quickly, and and it was just a very, very arduous journey for her. But I think she's now where she's at, but man, that probably took her at least 5 years to.
So there's that extended recovery for some of these unforeseen circumstances that could show up post op. And that just, you know, again, it goes to the fact that it's not an easy recovery for some people. It's not
Yeah.
easy in general, but some things show up and it could prolong that even further.
So I get, we need to educate our clients in the reality of the surgeries and the outcome of the surgeries, because we know surgeons are completely selling them in their effectiveness and their speedy recovery, which we know.
Many of them are. Yeah.
Yes.
Yeah.
So, so we need to be aware of that. But we also, I think we also need to be aware of educating our clients in their rehab journey before they even get to that point, right? Like, what is your take, Munira, like when you work with a client who's had diastasis for, how long do you work with them before you even start this surgery dialogue with someone? Like, do you mention it right at the beginning of your intake with someone, or how do you kind of weave this into your plan of care?
Well, I do keep it very generalized but I do try to keep it in the conversation, because for a couple of reasons. A, we just don't know how they will respond to what we do together, how their tissues and their body's going to respond. And B, at the onset, maybe on the first visit, we may not have had enough of the discussion around what it is that they want for their core, and like what happens if we don't get there. And so but I always try to mention surgery as part of the picture, and that we will do conservative management first. We have to try this stuff first if that's what they want. And that's usually why they're there in the first place. So like we'll do that first. And then we see how your individual body responds. And at the end of all of this, if you're not happy, or if we're not getting you to where you want to be, what we can help with is more of this strengthening piece. And sometimes along with that, we end up seeing changes in how you look. But I can't be there to promise you're going to look like this certain image with what we're doing. If you get there, that's great, but I can show you the exercises that will certainly help to strengthen and build your core back up. And so I try to keep it in there. I don't push it on them, but I also don't come across as against the surgery or anti-surgery. And I try not to make those false promises. I just try to lay it all out so that they understand that when it comes to diastasis, surgery is part of the picture for some people. And for them to be aware of that, it's good, because maybe they came in, but they kept it to themselves, that they were already thinking of surgery in the first place. So I want to keep it all open. That way they don't feel judged or afraid to say anything to me.
Yeah. Great. Lisa, how do you approach that? And then I want to jump in on those false promises.
Yeah. So I want my clients to feel empowered in their decision. So I like doing that with, going the route of, we're going to get you strong and feeling good. And at that point, you'll have a better understanding of, you know what, I feel okay. I might not exactly like the way I look, but I feel strong. I feel okay. And they may decide surgery is not for me. Great. Or they may get to that point and say, I don't know, I think, I'm feeling good, but this is still bothering me enough. I might want to explore that. And then you can kind of go down that road more specifically to make sure they get all the information. Again, feel very empowered and are able to advocate for themselves when talking to surgeons and figuring that out. But we can never promise them how they're going to look. Like Munira said, we want them to feel better, but everybody's body responds very differently. And people want the promise that their stomach's going to look flatter. That's what they want when they're doing exercises. And I make sure that we don't promise that. But on the flip side to this, we also can't promise them that if they get the surgery. This is a huge talking point that we have. So many women have reached out to both of us, and they are just devastated post-surgery because they don't look washboard flat all the time, any of the time. And just because you're getting tummy tuck surgery does not mean that you are promising a stomach that looks a certain way and super flat all the time. And I think that's one of the most important things we can educate clients on, because especially the clients that are like borderline, or the ones that we don't think need surgery, they run the risk even more so of absolutely being devastated after surgery. They're like, what the heck? This isn't even that much better, because now I'm bloating in a different spot, or now I have this large scar on top of it and I'm not even that much flatter. Right. So it's very, I mean, it can feel complex, but really when you have the conversation and really explain that so they're aware, you know, I show a lot of pictures of my belly to people so they can understand. Now, for me, I had a very extreme case, and I also had realistic expectations going into it. So I'm totally fine. I feel great, but other people might not be okay with me.
Yeah.
Like, right. So in my situation and how I look, and I look drastically different when I'm active at the gym. I look jacked. The end of the day, after I eat a meal, I am not flat. Okay. And I'm a human. But women don't, plastic surgeons show them a picture. Look at my work, which you need to look at, because artistically it's an art. So you need to look and say, I don't know, I don't really like their jive. I don't really like how they do that belly button. Then you want to find someone else. I mean, it's important to look at them. But when you're being flashed still pictures of a belly over and over, it's very, very, very dangerous.
Yeah. Why is it that, I mean, our culture is so stuck on flat bellies? We're not meant to be flat as women, as even men, really, are we?
Right. Right.
Everybody's different. Every body is different. It doesn't account for, like what Lisa was saying, eating and digestion, and not just bloating, but just kind of movement and muscle fatigue. You know, it, like whether you have done a workout or if you haven't worked out, like, yeah, there's, I feel like there aren't any bones there for a reason. to give room for stuff like that.
It's supposed to expand everybody. Yeah, and that's one thing I think, post-surgical. I don't know, do you guys do any hands-on work, like manual therapy to an abdominoplasty, belly that's had abdominoplasty?
There are a lot of techniques that can be done. I'm not doing those right now because mainly I'm virtual.
Okay.
But, there's a lot of manual techniques that can be done for even like lymphatic drainage and scar massage and restricted fascial, you know, maybe adhesions and tightness and lots of stuff. Yeah.
Yeah, I've been so amazed at working, you know, when the bellies come in post-surgery, they're rock hard, just rock hard, and just laying your hands on them without really doing anything can really just soften the tissues and just give it a little bit more breathing room, space to kind of relax a little bit. So I'm a huge fan, as you all know, I'm a huge fan of manual therapy techniques and doing the hands-on work. And you know, I wouldn't be aggressive at all, but I'm just wanting to point out that just laying your hands on someone that has that really hard belly can really kind of soften the whole system. And, you know, it's been through a trauma. That surgery is not an easy thing.
Really, really, really hard to like learn how to relax your belly again. I remember at one point at 5 weeks, I was like, am I ever gonna be able to relax my belly? It was awful. And other people can relax a lot sooner than that. Everyone's on a different timeline, but
right.
And I had someone, you know, loving on my belly, and I had a lot of support and all this stuff. But it's really hard, and most women don't get any help. They're just
yeah.
That's why we made Tummy Tuck Rehab.
Yeah. Well, Lisa, did you have a hard time touching your belly after the surgery?
Oh yeah, because it feels numb and weird, and I was scared of it, and you know, there's things I have to do with that.
Yeah. Okay. Well, cool. Well, let's dive into, tell us a little bit about this course that you guys are putting on for professionals to help us to understand how to better support our clients that might choose to go down this road, or tell us more about this course you guys have.
Sure. So it is a course for fitness and rehab professionals, and it was something that was created out of this knowing that there is this need for some quality resources for people who want to help those who are going for the surgery but don't necessarily know how, and themselves are afraid of doing damage, or not knowing how to work with an abdomen that's just gone for surgery. So we kind of bridge that gap where we provide a whole outline, like a program of exercises that can be done right from the beginning until they're potentially 6 months or later post-op, so that the individuals who are going through it begin to feel like they can trust their bodies again, they become reconnected again and stronger, and then they could go back to doing whatever fitness they wanted to do. And so we teach the professionals a series of exercises, but then we discuss the ins and outs of the surgery. We discuss the psychosocial factors around it, including everything we've talked about here and then some. And it's an introductory course, meaning we're going to add more to it as the years pass and as we have more to offer. So, and it'll be out by the time this podcast airs. It should be out. And yeah, we're really excited that hopefully people will be able to get more help that they need, that the clients will get more help that they need.
Great. Awesome. Anything you want to add to it, Lisa?
Nope. I'm just, we're super excited. We've been working on a lot of stuff for a while, so we're excited to have one of our programs ready to go.
Awesome. Well, thank you guys so much. And I want everybody to know that Lisa and Munira are going to be on the Birth Healing Summit this year, and we are going to do some myth busting myth busting around abdominoplasty and tummy tuck. So please check out that interview and the summit. We're gonna deepen our conversation here. But I hope that everybody here listening in really takes away this idea that we need to put our biases aside, really meet our clients where they're at, and no matter what the width of their gap, know that any person dealing with diastasis recti may be a surgical candidate because in their mind, they're not happy with their results. And, let's help be aware of not promising false promises to our clients. And any last words you guys want to add to that before we say goodbye? Munira?
Yeah, just let us just be very mindful of like what we're discussing and how we're discussing it with our clients regarding the surgery. We don't want to scare them, but we also, like you said, don't want to give them false hopes or false pretenses of what they might be able to expect after.
Yeah.
I think it's always important to always bring back to your clients this idea of a team. Body image is complex. Mental health therapist is always great to have on board before going through a surgery like this, even if they seem pretty like, no, it's a really, most women we talk to are like, oh my gosh, I didn't realize how mental this was going to be, like the whole process. So having that kind of support for them, for their brains, is another great person to get on their team, right? So you've got, the physical therapist, the physio, if they work out, someone like me who specializes in, fitness stuff, a mental health therapist, nutritionist for when they're recovered, right? Like we really want to sell them on the team if they're going to get the surgery, because a lot of people just go in, they have the surgeon, and that's it. And it will really help if they have a good team.
Awesome. Well said. Well said. All right, everybody. Thank you so much for listening in. Thank you, Lisa. Thank you, Munira. And we will see you all on the next episode. Take care, everybody. Bye-bye. Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code podcast50 at checkout. Till next time, I'm Lynn Schulte, founder at the Institute for Birth Healing.